Hello, my name is Jessica Dell'Aquila, and here we are with APP to APP virtual lectures. We have two viewer audiences, APP to APP and My Catholic Doctor. Like I said, my name is Jessica. I'm a physician assistant. I currently practice in surgery at Penn Medicine, and I am part of the AAPA's Nutritional Fellowship cohort. So this lecture is going to be covering nutrition and wounds. Okay, so our outline today is going to be wound overview, wound pathology, how do we define malnutrition, epidemiology, and the overall cost of malnutrition for the health system as a whole, screening methods to identify malnutrition, as well as how do we manage wounds, and how does nutrition play a role in the management. So wound overview and pathology. So there are many different types of wounds. We have pressure injury wounds, which are decubitus ulcers, arterial and venous ulcers, as well as diabetic ulcers. A lot of the research regarding nutrition is done with pressure ulcers or other pressure injuries, but it can really be applicable to various types of wounds. So if we continue, this is a basic pathophys review. So it's a pretty complex process when we talk about a pressure injury, and there's different ways that they can occur. So mechanical pressure over bony prominences over long periods of time can cause ischemia of that tissue. When we have shear friction of the skin, it can affect the capillary beds, as a lot of us have seen as well in the inpatient setting. When you have excessive moisture on the wounds, that can lead to further ischemia and damage and skin breakdown. And then actually a lot of times what we don't always think about is the reperfusion injury. So in the inpatient setting, if we're turning a patient, which is obviously essential to help prevent some of these pressure injuries, what can actually occur is that once there's normal blood flow returning to that area or reperfusion, it can advance the tissue damage that was already starting. So here we have our pressure injury staging. So this is something that is always available and up to date, and I refer to it pretty frequently. And this is kind of how we stage our wounds. So stage one is the skin is still intact and there's no surrounding erythema. Stage two is when we start to see some partial thickness loss. Stage three, we're getting to the point now where we're seeing underneath dermis structure, so adipose tissue. Stage four, we have full thickness loss, and you can start to see some fascia or tendon in that area. And then unstageable is usually when we get to the point of an eschar or sloughing of the skin. So risk factors for pressure injury. So patients that are immobile or have difficulty with mobility, aging, comorbidities, sensory loss in that area, which kind of ties in with the comorbidities, and we'll get into that in a little bit. And the main focus of this lecture is going to be malnutrition and how malnutrition puts us at higher risk for ulcer injury. So on this slide, we're going to briefly discuss the Braden scale. So this is it's a scale that's often used in the inpatient setting, a lot of times by nursing staff, and it helps evaluate how at risk we are for developing more so pressure injury. So as you can see, it breaks it down by sensory, moisture, activity, mobility, nutrition status of the patient, as well as risk for friction and shearing of the skin. So when we do this assessment, the lower the number that the patient scores on, the higher the risk they are. And a lot of inpatient centers actually, it becomes almost like an automatic default, where if a patient on the assessment by nurses scores a certain number, it'll automatically consult the dietitian team, which is a really cool implemented tool in the inpatient setting. So next we're going to get into arterial and venous ulcers. So a lot of this might be a bit of a review from, PA school material, but arterial ulcers, basically the mechanism there, the pathophys, is limited arterial blood flow that will in turn decrease oxygen and nutrient delivery to the area. And of course, without nutrients, we start to have tissue and skin breakdown. So risk factors for this would be smoking, a sickle cell patient, any type of vasculitis. And then we get into venous ulcers. So venous is a little different because it's usually due to valve failure within the vein system. So this, you're going to start to see edema more so, pigmentation and ulceration. And as you can see in this image, I actually feel that this is more of a mixed picture because you see you have some of that hyperpigmentation that we see with venous disease. But also, if you look, the area of the skin is pretty shiny, which points more towards an arterial process. So it's important to note that you can also have a mix of both. And then we get into diabetic ulcers. So these are very commonly at the bottom of the feet. This is a multifactorial process. It can be, from high blood sugar, hyperglycemia, or hyperlipidemia. And the reason that this causes diabetic ulcers is it leads to a sensory neuropathy. So we have the patient will have an issue sensing the pressure at the bottom of the foot, and then that can also lead to some issues with bony prominences as well, and overall decreased flow to the area. So when we have those bony prominences as well, we see an increase in the friction and the pressure. So this is super important for our primary care folks. A sensory exam and examination of the bottom of the feet should really be done on any pre-diabetic or diabetic patient. So when we get into the discussion of wound healing itself, it's a three-process system. So inflammation, proliferation, and then the remodeling. And all three of these stages, nutrition is immensely important, specifically our caloric intake and our protein intake. So this graph basically just goes over a brief overview of the nutrients that are necessary for wound healing. So I briefly touched on in the other slide, calories and protein. So the calories help preserve our lean body mass, and the protein helps build and support the lean body mass. The big issue when patients are malnourished and trying to heal a wound is that a lot of time they don't have the reserve from their caloric intake or protein intake. So they start pulling those resources from lean body mass, which just further worsens the malnutrition issue. We're going to further discuss a lot of these micronutrients and elements, but basically fluids also become important, vitamin B12, C and E, zinc, and then we get into sort of our amino acids that become important too, specifically arginine and glutamine, which we're going to get into, and hydroxymethylbutyrate, which is a byproduct of leucine, which is an amino acid, and we'll get into that. So now we're going to basically cover malnutrition itself. So it's basically defined by any nutritional imbalance, and this is a standardized definition by Aspen and the American Academy of Nutrition and Dietitians. So the 6 boxes in the screen are basically what we use to help define malnutrition. So if a patient has any 2 of those, they technically are considered malnourished. And the way we really determine if a patient is malnourished relies incredibly heavily on our history and our physical exam, more so than diagnostic tools. Something I do want to touch on, though, is that I think it's very interesting to note that BMI is not considered part of this. I think that sometimes BMI can be misleading, but it is very possible to have a patient that is technically obese or has an elevated BMI, but still is malnourished. So that's something to keep in mind as well as we progress through the lecture. So the background. So malnutrition is a very strong risk factor for wound development. These patients that are malnourished have an increased morbidity, mortality. They have longer hospitalizations, and specifically with surgical patients, we see that they have a much higher readmission rate after discharge. So for wounds and malnutrition, so again, it is a large risk factor for the development of pressure injuries. Inadequate caloric and fluid intake, as well as the weight, are associated with inadequate wound healing as well. And again, we see an inadequate level of nutritional intake when it comes to calories, protein, macro, and micronutrients. So I briefly want to get into the epidemiology of malnourished patient populations, as well as the cost. of malnourishment overall for a healthcare system. So it's interesting because if we look at our inpatient setting, whether it's hospitalized patients, or patients in rehab facilities, about half of them are actually malnourished, but we don't always do a great job as clinicians as we should be identifying this. So populations at the highest risk for malnutrition would be the elderly, any patients with comorbid conditions, specifically liver disease, end-stage renal disease, heart failure, diabetes, and other cardiovascular diseases. Patients with poor oral health. So if you think about it, as we see this a lot with the elderly as well, poorly fitting dentures or poor dentition, pain with swallowing, that'll all play a role in the nutrition of the patient. And then, unfortunately, there are socioeconomic factors that do play a role. So it's important that we do, as clinicians, have those discussions with our patients. So the economic costs of malnutrition. So overall, malnutrition drives longer hospitalization stays and a greater likelihood of readmission, which is a huge burden from a cost perspective on the healthcare system. It's funny when we just, we in a lot of fields of medicine, we talk about the importance of preventative care, and nutrition 100% falls into that category. And just for kind of a comparison, every $1 we spend on nutrition and preventative measures for patients is basically equivalent to the $52 that we expend in hospital dollars caring for a lot of the pressure injuries and the wounds that these patients will develop if we don't catch this early. So wound and nutrition outcomes. So again, the risk factors is length of stay, length of stay, comorbid conditions, the stuff we covered in the other slides. And the reason from a cost perspective, it's important to address this is that it will affect the length of stay for the patient, the readmission rate, and overall occurrences of wound development. So this is just kind of a quick reflection question from what we've covered. So up to what percent of hospitalized patients are estimated to be malnourished? We briefly covered this, so I'll give you guys a second to pause or think about the answer. You can pause the video. So it is about 50%, and a lot of that isn't represented in our clinical documentation either, because we don't always recognize it. So screening. So how do we screen for malnutrition? So a great method that you can do with a patient, and this is part of your history, is the 24-hour recall. So ask your patient what they eat in a typical day, or ask them to physically log it and then bring it back to their next appointment. So, it's important to keep in mind that everyone's typical day may look different depending on their line of work or if they travel, etc. But really getting an in-depth detail of what their day-to-day food intake looks like can be immensely helpful. So the 24-hour recall, these are just some examples. And the key thing I want to focus on during this slide is that, yes, you should ask them what they had for breakfast, but then get detailed. So if they had eggs and toast, what did they put on the toast? So if they just put butter on their toast, there may be an opportunity to discuss with them about adding something like almond butter to increase protein if that's an area they're lacking. So details are really key here because it gives you kind of the little areas to adjust for the patient or alter their diet and give suggestions. And this slide specifically focuses on protein. So just kind of reviewing with the patient how many grams of protein are in what they're eating. So this slide breaks down animal sources of protein, so meat, milk, and then it also gets into starches and veggies. So a lot of patients sometimes think we can only get protein from animal sources, but a lot of vegetables have a pretty significant protein gram. So it's important to put that into your conversation as well. So estimating protein, this is again important because it goes over the issue of portion and size control, which in the United States, we have a very skewed portion control system. So it's important to reiterate this. So one deck of cards, I actually prefer that over the palm because everyone has different size hands. So a deck of playing cards is an appropriate amount of meat, and that's 3 to 4 ounces. And if we go back to the previous slide, you can see 1 ounce of meat is about 7 grams of protein. So if somebody has a 4-ounce chicken breast, that's about 28 grams. So that's a decent amount of protein. And then we are going to get into the physical exam. So when you are clinically assessing the patient, what things can kind of give you a cue for malnutrition as a concern? So first, we have our hard, fast data, right? We have our height, our weight, vital signs, BMI. Again, I will reiterate, I don't love BMI. It is still pretty standardized care that we use BMI. I just don't think it's as reliable. So what I like to do is look at weights of patients, and I like to trend the weight. So to me, the trend is the most important thing. So if I see a patient that is consistently on visits losing weight involuntarily, that is absolutely something that needs to be addressed. Cranial nerves. So this is something we don't always think about in our physical exam, but are all the cranial nerves intact? Because that affects our ability to chew properly, for saliva, for swallowing. So that's an assessment that should also be done with the patient. The next category, oral cavities. So we touched on this a bit earlier as well, but assessing your patient's dentition. If your patients have dentures, do they fit appropriately? A lot of times as patients lose weight, their dentures will not fit appropriately. Does the patient have any oral ulcers causing pain in the mouth that makes eating difficult? And then from a peripheral vascular perspective, is the patient widely edematous? That can always be a sign that something's off, specifically with our protein intake. So in this picture, we have a patient, and I just kind of want to give you guys a few minutes to start thinking about, on a physical exam, what would look off to you about this patient in terms of a nutrition risk with some of the things we discussed. So take a second, pause the video, and then come back. So as you can see, maybe you wrote some of these down on your sheet as you were going through it, but we have wasting of the temporalis muscle. So he has some pitting at his temple area. There is also lean muscle mass loss around the clavicles. The one thing I really noticed as well was loss of orbital fat pads. The patient tends to look like he has poor dentition. And then he has atrophy as well of his intrinsic hand muscles. And we're going to discuss the actual physical exam, but hand grip strength is actually a very important physical exam assessment tool that you can use for malnourishment. So now, as we're getting into, this is the physical exam component. So this is actually a grip strength dynamometer, and I personally don't use this in clinical practice. What I instead have the patient do is I cross my fingers like this and have them grip, and I can assess the grip strength that way. But this measurement tool actually gives you a data point, which is pretty interesting, and you can trend those. I think a lot of geriatric practices do have these. I personally don't use them in clinical care, though. And again, there are a variety of screening tools from PONS has a pretty popular one. This one is used mainly in surgery in a preoperative setting. So it goes over BMI, albumin, and then the discussion of unintentional weight loss. And then the malnutrition universal screening tool is one that's more so used in primary care. The one thing I will say is, out of all of the history questions you can ask a patient, I do think unintentional weight loss over a certain period of time is probably the most important, and that should cue you into either doing a more in-depth workup or getting a dietitian consult started for the patient. So now we're going to get into diagnostics. So the most popular diagnostic tool for malnutrition is albumin and prealbumin. And while they can have some benefit, there are definitely barriers to utilizing these lab data points. They can go up in acute phase reactants. They can be altered in liver disease or other chronic comorbid conditions. So I always take them with a grain of salt. A CBC is always important because it can kind of clue us in about an anemia that's developing, which we can typically see with malnourishment, especially if we get into like microcytic anemias. We could maybe have B12 deficiencies, folate deficiencies. A CT scan, it is part of the diagnostic tool set. However, I don't see it used as much in clinical practice because, to be honest, you can usually evaluate lean body mass loss on your physical exam. Zinc levels, these become important when you're actually supplementing somebody with zinc, and we'll get into that a little bit later. And then glucose levels. So again, is the patient's diabetes well controlled? If not, if they're having persistent hyperglycemia, that is just going to further malnutrition. And if there are any wounds, it is going to hinder the healing process. So this is also just kind of a reflection question from what we've covered. So what are some critical screening tools that you can do as a clinician with your patients to assess nutrition risk? So again, I would encourage you to pause the video, write down some answers, and then come back. But what some of the answers would be, I would say utilizing your 24-hour recall, your physical exam assessment, and then some of those diagnostics that we did cover. And then also part of this critical screenings tool should also be asking the patient about their access to nutritional food. All right, so our next topic here is actually the management of wounds if they develop. If we get to the point where we kind of miss the preventative measures and now we have a wound to deal with. So what do we do? So it's very similar for all wound types, whether we talk about our arterial and venous ulcers, our diabetic ulcers, or pressure injury. I would like to note, though, that most of the research and data is done in the context of pressure injuries because they're done with long-term patients that are usually hospitalized. So that's just important to keep in mind. So when we talk about nutrition, so the important things are that the patient has a bit of a higher caloric intake and protein intake than what's typical, especially if they're in a state of healing. We're going to touch on essential amino acids like glutamine and arginine, vitamins, and then minerals such as zinc. So when we talk about wound healing, our caloric intake when we're in the process of healing is higher. So when we're in the process of healing, we want to aim for 30 to 35 calories per kg per day. Same thing goes for protein. So our typical protein requirement as an adult is about 0.8 grams per kilogram per day. When we're in a state of healing, especially for wound breakdown, we're looking at a 1.25 to 1.5. And again, I would like to say with the caveat that this depends on your patient's comorbid conditions. So if you have a patient with renal disease, that might change a little bit. So always take into consideration the whole picture for the patient. And then oral nutrition supplements may be necessary if unable to meet needs through a diet. So that's something that a dietitian consult can definitely help with. And this is just an overview of some protein sources. So again, take into consideration the whole patient. So if you have a patient with cardiovascular disease, maybe staying away from the beef sources would be better. All right, so next is our amino acids. So in terms of amino acids, there are two types. So we have non-essential amino acids, which is what our body can make, and then essential ones, which are ones that we get from diet. So arginine is actually semi-essential. So we get it from our diet, but can also help produce a bit of it. So this helps with our nitrogen balance, and it can sometimes be tough to get strictly from food sources. Glutamine is another one. This is the most abundant amino acid in our plasma. This fuels our immune system and immensely increases during wound healing. The next amino acid we're going to touch on is, let's see, it's leucine. So this is important for protein synthesis. We need about 2.5 to 3 grams per day. Hydroxymethylbutyrate is the metabolite of leucine that also reduces our protein degradation. So it helps us utilize, or not utilize, excuse me, our lean mass, which is what we want to hold on to. Fluids, so when we have a wound, there's actually a big risk for insensible losses, especially if that wound is moist. So we always want to keep in mind that the patient may have dehydration as well. So making sure that they're keeping up with their fluid intake. Vitamin C is a water-soluble vitamin, and we want to supplement this during wound healing, specifically to 100 to 200 milligrams per day, but you can go up to, you can go up to 1 gram. It is a water-soluble vitamin, so anything you don't utilize, you'll just excrete. And something I like to note here is most people think with vitamin C, you have to get it just from citrus, but you actually get more bang for your buck if you do a cup of bell peppers. So it's in your veggies too. Zinc is something else that is supplemented with wound healing. Usually we would only prescribe zinc for a certain amount of time. And it can be important to check the levels as well, because zinc can actually displace copper. So it can kind of throw off immune function and cause GI distress. So that's an important one to monitor as well. And this is a supplement that the patient should not be on long-term. And these are some great food sources for zinc. So those can be reviewed with your patient as well. And then when we get into how much support we need to give the patient during wound healing in terms of supplementation, really during stage 1, we just need to make sure they're getting enough protein and calories. Once we go beyond stage 1, that's when supplementation with zinc, arginine, and other antioxidants and vitamins becomes pretty crucial. And then oral nutritional supplements. So this is something to address with your patient if you feel like they're not meeting their caloric and protein needs. So this is utilizing high protein shakes, things like that, to help get the patient there. A lot of times, these patients will turn towards like high protein shakes because they don't have as much satiety and discomfort with them, and it gets them to where they need to be nutritionally, as opposed to having it all through like lean meats and things that maybe are a little harder to digest. So again, high protein supplements is the key here. It's important to educate your patient as they're shopping for these that unfortunately in a lot of grocery stores, they're in the same aisles as weight loss shakes. So you want to make sure your patient is getting ones that have high calorie and high protein, especially for addressing malnutrition. And then you can also look into supplementation prescriptions for your patients that contain vitamins, omega-3s, essential amino acids. Those are all beneficial for wound healing. And I always like to recommend, if you're ever not sure how to prescribe or what to do, having a consult out to a registered dietitian is very beneficial. And again, kind of getting into that, when do we really refer to a registered dietitian? So in the hospital, I always recommend a dietitian following with the patient, especially if they have chronic comorbid conditions, and definitely if they just had surgery. And again, the big thing here with nutrition is early recognition. If you think a patient is moving in the wrong direction, and getting a registered dietitian on board, supplements on board, and really just going over the lifestyle changes with the patient in regard to their diet as well. And then the last thing to consider too is the socioeconomic status of the patient and concerns they might have from a financial standpoint or an access standpoint. So that's always something to consider. And especially with our elderly population, getting family involved can be really helpful too. These are the references. Thank you so much for your time.